Hi, good evening, everyone. Thank you for joining us for our event, Slow Digestion. It could be gastroparesis. We are thrilled to have Dr. Kais Zakharia, also known as Dr. Zach, as our presenter. And just as a reminder, you can type your questions in the Q&A box. We will get to those at the end, not the chat function, but the Q&A box. And we'll be sure to leave time for questions. And so with that, I will turn it over to Dr. Zach. Dr. Zach, thank you very much.
Thank you. Can you hear me?
Yes.
Okay, awesome. All right, so thank you for joining us today. We will be talking about gastroparesis, a problem that can be really devastating to some patients. We will discuss what we can offer at Bay State for this disease. For some reason, okay, here we go. So I realize that most of the audience will be general population, not necessarily with a major medical background. So I'm going to start with the very basics. So I'm going to start with the anatomy of the GI tract. So here on the left, you see the esophagus, which is the feeding pipe, and then you have the stomach. The stomach is followed by the small bowel that is really long, and then eventually the colon, and then the rectum at the end. If we take a closer look at the stomach, it has this part that we call a fundus. We have this part that we call the body of the stomach, and then the antrum over here, and then eventually the pylorus. The pylorus has like a circular muscle, so it looks like a muscle that is like a circle. It opens and closes to allow the food to move forward. So to look at how the stomach looks, I have this figure that shows, when the food comes to the stomach starts filling up with the food. The food is non-digested, big in pieces, and then the stomach start mixing the food with the digestive juices and the acid, and it breaks down the food to small particles. And then during this phase, the pylorus, which is again is like a muscle that is circle, it will be closed. It prevents the food from going forward until it's well digested. When it's well digested, the pylorus will nicely open up, and that will allow the food to move forward to the small bowel, and that's what we call the emptying phase. So what's gastroparesis? Gastroparesis basically means the stomach is lazy. It's not moving as supposed to. It's not contracting well. That leads to delayed gastric emptying, so the stomach will not empty well in the absence of mechanical blockage. So it's very important to make sure the pylorus is not blocked from either like a mass, a cancer, or like anything from outside the stomach putting pressure on that area. So it's very important to rule out mechanical blockage or mechanical obstruction. So the patients usually present to us with chronic symptoms, nausea, vomiting, early satiety. So they feel they're feeling full sooner than usual when they eat. They present with bloating after a meal, abdominal pain, and if the gastroparesis is severe enough, it can cause also weight loss and malnutrition. So this is a scoring system that we use to evaluate the severity of the symptoms that the patient present with. So frequently when I get a patient in the clinic with gastroparesis, I ask them to fill up this table. So they give a score for their symptoms depending on the severity. And eventually we calculate what we call gastroparesis cardinal symptom index, or GCSI score. And that will help us evaluate the patient before and after any intervention we do. So what are the causes of gastroparesis? Number one, probably one of the most common causes would be diabetes. Diabetes, if the blood sugar is not well controlled, it can lead to injury to the the nerve endings in the stomach, and that can lead to decrease the motility of the stomach or the movement of the stomach muscles. Cause number 2 is the viral infection, also very common. Usually it's self-limited. We have been seeing more of gastroparesis after the COVID-19. Usually, again, those patients will have self-limited. Sometimes it can be persistent. And then after surgery, so in the human body, there's the vagus nerve that controls the motion or the movement of the gastric muscles. And if that nerve is injured from whatever surgery the patient got, that can lead to gastroparesis, also fairly common. And also medications. There are several medications. It's a long list of medications that can affect the motility of the stomach. Opioids, narcotics can cause it. Antidepressants can cause it. Some of the new diabetes medications and those medications that we use for weight loss, like Ozempic, Mounjaro, those are also associated with gastroparesis. Sometimes we get patients to the clinic with gastroparesis that is confirmed, and with the gastric emptying study, which we will be talking about later. And I look at the medication list and I see, for example, Ozempic, and I ask the patient to stop that, and we repeat the study, and the study comes back normal. So those are the medications that we pay attention to. Cannabis, marijuana is a well-known risk factor or a cause of gastroparesis, also very common. See it all the time. That's why when we check for gastroparesis, we have to make sure the patient stopped marijuana for several weeks before we do the test. And then unfortunately, in 30% of the cases, we don't have a clear explanation for it. So how do we make a diagnosis? So the patient will present with suggestive symptoms, again, nausea, vomiting, early satiety, bloating after a meal. And then we start the workup with upper endoscopy, or what we call EGD, to rule out obstruction, to rule out mechanical obstruction. As we mentioned earlier, it's very important that we rule out like a cancer blocking the pylorus, or like a stricture, or like an ulcer that healed and led to narrowing in the area. So those are also like very important to rule out. And then once we confirm that the endoscopy, this is how we do in the endoscopy. A patient will be asleep. We go through the mouth and we look inside the stomach and the small bowel. The very first part of the small bowel we call duodenum. So once the endoscopy confirms that there's no mechanical blockage, then we do a study that's called gastric emptying study. So in this study, we give the patient a meal with a radioactive tracer, and we use a special camera to track that meal and see how well the stomach is emptying. So normally at 1 hour, so we image the patient at 1 hour, 2 hours, 3 hours, and 4 hours. So at 1 hour, normally the patient should have less than 90% of the food he or she ate inside the stomach. At 2 hours, less than 60%. At 3 hours, less than 30%, and at 4 hours, less than 10%. So if a patient does that study, and at 4 hours, say the patient's having 50% of the meal he ate, that confirms the diagnosis of gastroparesis. But again, after the endoscopy rules out a mechanical blockage. So what are the treatment options? There are several treatment options, starting with diet modification, controlling the blood sugar, optimizing the blood sugar, hydration. We want to make sure the patient is well hydrated, because their ability to eat or drink is significantly decreased in some cases. So we want to make sure the patient is well hydrated. Unfortunately, and then also pharmacotherapy, like we have some medications that increase the motility of or the movement of the stomach, the contraction of the stomach muscles. Unfortunately, 30% of patients do not get any relief with what I mentioned earlier, and those are the patients that will need further treatment, either endoscopically with a scope, surgically, or with a gastric pacer. So we're going to start with diet modifications. So it's the first line. It usually works for mild gastroparesis. And it only has a mild effect on the symptoms. We recommend the patient to follow a low-fat and low-fiber diet. Now, those are the kind of food that will take longer to digest in the stomach. We also recommend the patient to rely more on liquids than solids. Obviously, liquids will be easier to pass the pylorus than the solid food. And then we also ask the patient to eat frequent meals, but smaller portions. So instead of having 3 large meals, we recommend, I usually recommend doing 6 meals, but smaller portions. And then we also recommend avoiding carbonated beverages, and we ask the patient to avoid smoking and alcohol, as those can also affect or slow down the stomach a little bit. And then next, optimize the blood sugar. There's conflicting data about this, whether it helps or not. We know that if there's acute increase in blood sugar, that can affect the motility or the gastric emptying in patient with diabetes and in healthy controls. So it's always better to control the diabetes for other reasons as well. Additionally, high blood sugar can decrease the efficacy of the medications that works on the at the level of the stomach muscles. It can also decrease the efficacy of those medications. We will talk about those medications later. We call them prokinetics. It's very important. Nowadays, we have those new medications, the GLP-1 agonist, and those are like medications like Ozempic, Trulicity, Mounjaro, Wegovy. Those are the medications that treat diabetes, and can actually be used for weight management because it decreases appetite, but also it slows down the stomach, and it can aggravate the symptoms of gastroparesis. So it's important if the patient's complaining of symptoms, very important to avoid those medications if possible. And then there are other medications like Januvia or like insulin or like metformin. Those are the medications that does not affect the gastric emptying. And then next, we will talk about hydration and nutrition. Very important. Again, patients with severe gastroparesis will be at risk for low potassium, which can affect, it can be lethal. It can kill a patient. Again, in very severe cases. Also, hydration is very important. Patients tend to have low iron, low vitamin B12, some like the other vitamins, fat-soluble vitamins like vitamin A, vitamin K, vitamin E. Also, they can get low thiamine and folate. Those are very important for your body to function appropriately. And hydration can be through orally, like encourage the patient to drink more, and then those vitamins can be supplemented. But in severe cases, IV supplementation might be needed. IV hydration might be needed. We frequently get those patients admitted to the hospitals, and they will need like IV hydration. Sometimes IV iron might be needed. It depends on how severe the gastroparesis is. Prokinetics, those are medications that increase the movement of the stomach or the motility of the stomach. So they increase the rate of gastric emptying. We usually recommend them 10 to 15 minutes before meals. And then also additionally, we give 1 dose before bedtime. Some of the medications are metformin. Those are very commonly used. Domperidone, and macrolide antibiotics. So metformin is considered first-line therapy. It's FDA approved for less than 12 weeks, mainly because of the side effects. It can be associated with severe side effects, anxiety, restlessness, depression. It can also increase the level of prolactin, which is one of the hormones that produced in the body, and it can lead to side effects. Like in men, it can lead to breast enlargement, it can cause infertility. In female, it can affect the menstrual periods. It can also cause like breast milk leakage. And then also it can lead to QT interval prolongation. QT interval is basically a segment in the heart electricity. Prolonging the QT can lead to cardiac arrhythmia. Cardiac arrhythmia means like the electricity of the heart is not functioning well, which can lead to abnormalities in the contraction of the heart, and in fact can lead to death. Also, patients can have involuntary muscle movements like dystonia or tardive dyskinesia. Those are like medical terms we use, but they can be bad side effects. It's recommended, especially if we're using the medication for long term, to have some holidays. So take the medication for a few weeks and then stop. Despite that, again, this medication is not recommended long term. Same for domperidone. Domperidone is also another prokinetic medication, but it's not available in the US. Some patients can get it from Canada. It's used when metoclopramide is not working or if there's side effects. It works similarly to metoclopramide, and metoclopramide is a Reglan, by the way, and it works similarly. It has similar efficacy, but unfortunately, it can also come with cardiac risks. It can be very dangerous. It can also lead to increased prolactin levels in the blood, and that can also comes with side effects. It comes also with, it can interact with many other medications. So again, not a very good option long term. Macrolide antibiotics, those are the two antibiotics that are known to increase the motility of the stomach, erythromycin and azithromycin. Erythromycin is used orally 3 times daily before meals. It's not recommended to be taken longer than 4 weeks at a time. Usually the effect will disappear after those 4 weeks. We can also use IV erythromycin. Usually we keep those for patients who are admitted in the hospital. It can be used. We don't use it very frequently. Also, it comes with side effects. It can lead to toxicity in the GI tract, gastrointestinal tract. It can cause toxicity in the ear. It can increase the bacterial resistance. It can also affect the heart, and it can cause sudden death. So also not a very good long-term option. Azithromycin, similar. It has longer half-life, means it can be used less often, and the effect is longer. Fewer side effects, fewer interaction with other medications. It can still affect the cardiac electricity, and it can lead to dangerous complications in the heart. It works similarly to the erythromycin, similar effect, not very different also. So for the that's for the prokinetics. And then we have the antiemetics. Those are the anti-nausea and anti-vomiting medications. Those are also can be used in patients with mild symptoms, mild nausea and vomiting. It would not have significant improvement of symptoms if the gastroparesis is severe enough. Diphenhydramine is an option. It's an antihistamine. Ondansetron or Zofran is also an option, and prochlorperazine also an option. It comes with its own risks and side effects. So as you can see, like all those medications don't work long term. The side effects can be scary for the patient and for us. So I only use those medications short term, not long term. And usually patients with severe gastroparesis would not respond very well to it. So when patients come with refractory symptoms, refractory means like they're not responding to any of what we already discussed. First, we reevaluate compliance. Is the patient following low fiber, low fat diet? Are they taking small frequent meals or not? Are they taking their medications? Are they still using marijuana? So very often, like marijuana, as I mentioned, it's one of the important causes. So very important to stop marijuana. Are they smoking? Are they drinking alcohol? And then we evaluate for nutritional support. Does the patient look dehydrated? Do they need to be in the hospital? Do they need IV fluids, or do they have like iron, low iron, or like low vitamins? So all those things needs to be addressed during the visit. And then we talk about what's the best way to give nutrition, or what can we do to the patient. So we can place a feeding tube into the small bowel to bypass basically the stomach, and we can also place a tube into the stomach to vent the stomach. And then we can also evaluate whether the patient needs to have IV nutrition or not. And then there are some interventions that are directed at the pylorus. Does not necessarily increase the motility of the stomach, but it decreases or it improves the opening in the pylorus. Hopefully, that will help with the symptoms. And then eventually, the gastric electric stimulation using the gastric pacer, which we don't really have at Baystate. You would not find it in many institutions, only in the very big institutions. I'm not a big fan of that device. I don't think it works very well, or it can work, but it can be really difficult to manage. So we're going to talk about decompression and feeding. Again, we have two different kind of tubes here. We use a gastric tube where we go through the abdominal wall directly into the stomach, and we leave that tube. That tube is not being used should not be used for feeding. We just use it to vent. So even if we're not eating anything orally, the stomach is still producing significant amount of fluids per day, and that fluid needs to be vented out. Otherwise, patient will still have symptoms. And then we use a direct J through the abdominal wall, but into the small bowel, bypassing the stomach, and that tube can be used for nutrition. Again, those are left for a very severe gastroparesis as a last resort. And even if the patient is having a feeding tube into the small bowel, we can still permit like small amount of liquids per day, just for pleasure. Patients will need consult with the nutritionist to manage the formula that needs to be pushed into that tube. And in some cases, if the gastroparesis is severe, patient might need nutrition through an IV, so bypassing the entire GI tract, and that again only in very severe cases, but we see that frequently in the hospital. So this is what I want to discuss, or I want to focus on today, is what can we do at the level of the pylorus, which is again the muscle that opens and closes to let the food out of the stomach. So we have a few options here. First, transpyloric stent. stent to keep the pylorus open. Botox injection is something that used to be used in the past, not very effective now. We have gastric per oral endoscopic myotomy, which is what I'm going to be focusing on today. Gastric, because we do it at the level of the stomach, so gastric. Per oral, because we go through the mouth. Endoscopic, because we do it endoscopically through a scope. And myotomy means we cut the muscle, because we cut the muscle of the pylorus. That's why it's called myotomy. And it's short for G-POEM. Okay. And then we have the laparoscopic pyloroplasty, which is also at the level of the pylorus, but it's done surgically. And we'll discuss that later. Let's start with a transpyloric stent. It can help patients, especially those with nausea and vomiting, not much in those with abdominal pain. It can be effective in up to 75% of patients. A great option. However, the complication rate might be pretty high, the risk of migration. The stent, even if we have some tools to fix the stent into the stomach on this side, but the risk of migration is still high. Migration means the stent moving forward into the small bowel. And it can be really ugly when that stent moves forward, because it can get stuck in the small bowel. It can cause perforation. It can cause obstruction. We have some longer scopes to chase it all the way to the small bowel. Frequently, we can be unsuccessful. Sometimes we go backwards from the colon side, and we're still unsuccessful. We recently here had a stent that was migrated. Not it wasn't placed for this purpose though, but the patient ended up having surgery to remove it. So again, not the best option, not a long-term option at least, because the stent cannot stay there forever. And then Botox injection. So in the past, we used to inject the pylorus with Botox, hopefully to relax it a little bit. But studies have shown that it does not cause does not lead to any improvement in the symptoms. So we do not recommend that in gastroparesis. Some people are still doing it, but we don't do it here at Baystate. Then I'm going to talk about the gastric poem, or G-POEM. Okay. So G-POEM, it was first reported in human patients in 2013. There was a meta-analysis. Meta-analysis means it's a type of studies that we use where they collected several studies, and they collect all the data from several studies, and they analyze the data as a whole. And that's why we call it meta-analysis. So there was a recent meta-analysis published in 2022. It showed that the clinical success means the improvement in the symptoms at 1 year was noted in 61%. That's what I tell my patient when they come to the clinic. I tell them that you have 60% a chance that your symptoms will improve after the procedure, but you have 40% chance that it's not going to improve your symptoms. The adverse events was noted in 8%, usually not severe complications, usually mild complications that we are able to manage endoscopically. There is this theoretical risk for dumping syndrome. Dumping syndrome happens when the food get pushed into the small bowel suddenly. It can lead to nausea, vomiting, some diarrhea, some electrolyte abnormalities. Again, I have done this so many times so far. I didn't have any problem. It's probably mostly theoretical risk. I always tell my patients when they come to the clinic to discuss G-POEM that this is not going to treat the gastroparesis. This is not going to make the contractions in the stomach stronger or more frequent. This is going to remove the barrier to the gastric outflow and hopefully make the contractions of the stomach more effective. But again, it does not cure the gastroparesis. What should the patient expect before the procedure? So a patient, we do this with just like an upper endoscopy, but it takes a little longer than the upper endoscopy. We tell the patient no food or anything per like orally overnight or over the last 8 hours, mostly for solid food. For liquids, up to 2 hours, 2 to 3 hours is fine before the procedure. We ask the patient to stop any blood thinners or any diabetic medications that can slow down the stomach, like the Ozempic medication, the Ozempic Monjaro. Those medications need to be stopped for 7 days. While, for example, metformin, we ask to hold the morning of the procedure. So very important to get clear instructions from the office about when to stop the medications. For blood thinners, some medications can be stopped 3 days before the procedure, like Eliquis, for example. Other medications like Plavix, which is also very common, we ask for to stop it for like 5 days. Also, we ask the patient to consult with the primary care or a heart doctor, see if it's safe to stop those medications. And then the patient comes at the day of the procedure, 60 days before the procedure itself. The patient will change clothes, they get IV in. We have a great team of nurses who prepare the patient very well. And then I come to the procedure, or one of my fellows come, and we talk to the patient about the procedure. We get a consent from the patient, and same for the anesthesiologist, who will come and talk to the patient about the medications that we will be using during the procedure. And after that, most of the time, we request general anesthesia with intubation, so the patient will not feel or remember anything happens after getting into the room. In fact, the patient frequently report that they got the best nap ever. Again, patient will have a breathing tube in their throat for the entire procedure. The procedure time, it takes around like 30 to 45 minutes, a little bit more, a little bit less, depends on how it goes. Very frequently, we admit the patient overnight for observation. Sometimes, if it's very straightforward, we can still let the patient go home same day. So to understand the procedure, I thought I should start from very basics to explain the different layers of the gastric wall. So if we take a piece of the gastric wall here and we look at it under the microscope, you would see the very first layer called the mucosa, and then followed by the submucosa. This is the space where if we inject any fluid, it will expand significantly. And that's where our procedure will take place in this space. And then you have the muscularis propria, or just muscularis. It's just a muscle layer. This is the layer that ideally should not put a hole in, because that will mean the patient will have a perforation. And then you have the serosa, which is too far from what we do. And then the entire procedure takes place in this area. This is the pylorus I was telling you about. It's like a circle of a thick muscle. So how do we do this? So using the scope, this is the scope. We start like 5 centimeter before the pylorus. This is where the pylorus is. 5 centimeter before that, we inject into that submucosal space, or the submucosa. When we inject, you can see here in this picture, it's expanding. When it expands, we can make a cut into the mucosa, into the submucosa, and then we can keep making a tunnel all the way until we reach the pylorus. Once we reach the pylorus, like here, once we reach the pylorus, we use the knife to cut the pylorus open. Once we cut open, hopefully it will relax a little bit, and we come back and we close that very first cut that we made in the mucosa. So the patient end up with a hole here in the muscle layer, but that hole is covered with the mucosa and submucosa. So the patient doesn't get perforation, at least no full thickness perforation. And we use those clips to close the what we call a tunnel. So we call this a tunnel. Okay, we close it. And then this is the knife that we use. I don't want to go too technical here, but I thought I should show you this. This is a really cool tool that we use. We use this metal part to cut. And if you see here, this small hole, this can allow us to inject. So when we inject, we lift, we expand that submucosal space. This is a nice video showing all the steps that I've just told you. So here we're starting with, after injecting, we're starting that tunnel. And then now we are in the submucosal space. See, we inject and then we keep cutting until the pylorus is reached. And then we come out just to make sure that we actually went across the pylorus. And now we can see the pylorus. This is the bridge that you can see here that I'm about to cut. This is the pylorus. So it's like this, we're cutting it from here. And now I'm checking that the pylorus is wider right now. And then now we use some clips to close that defect. Those clips are usually compatible with MRI. We get that question all the time. So if the patient is going to get an MRI, it should be fine. So this is another some nice pictures from a recent procedure that we did. Here, where we got into that tunnel until we reached the pylorus. You see the pylorus. You can see half a circle here. And this is the muscle. This is all muscle. And then here you can see this. We use this blue dye to guide us, and you can see like we made that tunnel into the right direction. And then here we cut that bridge, the pylorus. We cut it until it's completely disappeared, and then we close the defect or the opening that we initially made, and those are the clips. Usually the clips stay there for it varies. It can stay there for like a week, can stay there for a month, can stay there for a year, or even longer. So it varies from patient to patient. But most importantly, it's not a problem if the patient is going to get an MRI. So after a procedure, again, we admit the patient overnight. We admit the patient overnight for observation. We want to make sure the patient is safe. We monitor vital signs. We monitor labs. We make sure the patient white blood cells are not going up. We make sure the patient is not having a fever. Patient is not having symptoms, pain, or like nausea, vomiting, things like that. Usually, most of the time, we discharge the patient next day if the patient is stable. Sometimes, if the patient, for example, living across the street or very close to the hospital, we can discharge on the same day with no problem, assuming that the procedure went smoothly with no concerns at all. I usually send the patient on antibiotics for 5 to 7 days, just to make sure the patient doesn't get infected. I allow the patient to take liquid diet for 24 hours. If the patient is tolerating the liquid diet, then we advance as tolerated. Very important that before I do this procedure, we need to set up some expectations. So again, this is not treating the gastroparesis. We're not making the muscle contract like stronger, but we are making the opening a little wider. So the patient should not expect complete resolution of symptoms. Sometimes they can get some improvement of symptoms. Sometimes they can get complete resolution of symptoms. Sometimes they don't respond at all in up to like 30 to 40% of the patients. So this is the most recent study that looked at the long-term outcomes after GPOM. Again, it's a meta-analysis of 5 studies. They looked at the clinical success, and it was at 36 months, it was 75%, which is pretty good for 36 months. 75% of patients improved in their symptoms. That's pretty good. Technical success was almost close to 100%. The GCSI score significantly decreased at 36 months after the procedure, which is good. The adverse events was not very common. Perforation vary in almost 0% of the cases. The bleeding in 4%. Bleeding can happen during the procedure. It's part of the procedure, but in most of the time, or like almost all the time, we control the bleeding during the procedure. I never had a patient who had a bleeding afterwards, but it can happen. Um, um, in that case, we just have to go back in and try to stop the bleeding. Pain can happen also, but very rarely. The mean duration of hospital stay was 3 days, which is a little longer than what we see in the clinical practice here. Next is laparoscopic pyloroplasty. This is done by our colleagues from surgery, so we don't do it as a gastroenterologist. This is done in the OR. They go with the scopes through the abdominal wall, so they make a small incisions in the abdominal wall. They insufflate the abdominal wall, and then they go to the pylorus. They make this cut, and then they open it up, and then they suture it in the opposite direction, and that can make the pylorus a little wider. So there was this study. I'm not going to be talking in more details about this because I'm not a surgeon, but there was this study published comparing the surgery versus GPOM. Again, it was a meta-analysis. A good number of patients. They looked at the procedure time. The procedure time was significantly lower in the GPOM patients compared to surgery. Obviously, the GPOM is done by endoscopy. The mean difference was up to an hour. So it's faster in GPOM. That means less anesthesia time, less risks for the patient. The length of the hospital stay after the procedure was significantly lower in the GPOM compared to surgery. Again, usually for GPOM, if everything goes well, the patient will stay overnight at most, or can go home same day. And then the reduction in the symptoms or the GCSI score was not different between the two. So both approaches are effective. Similarly, the GPOM has the advantage of less numbers of hospital stay or less days in the hospital, and less procedure time compared to surgery. And then finally, I'm going to talk very briefly about gastric electrical stimulation, or the gastric pacer. This is also a cool technique, but it can be difficult to manage. It will require surgery, laparoscopy, similar to the what we discussed here. So they don't open up; they just do it laparoscopically. They basically use this spacer with leads attached to the stomach wall to stimulate the stomach to contract a little harder, and then they put that pacer under the skin. We don't do that here at Bay State. Again, there's only, even though this has been practiced for a long time, people are not, like physicians, are not very big fan of it. And again, we don't do it here at Bay State. It works mostly for patients with nausea and vomiting, not much for patients who complain of pain. There was this study that they compared the gastric pacer versus the GPOM, and they found that after 27 months. They looked at the duration of the clinical response after 27 months, and they found that the GPOM is better, and the clinical response was longer with the GPOM than the gastric pacer. Um, the 24 the 24 months response rate was 76 with the GPOM versus 53 or 54 with the gastric stimulator. The side effects or the possible complications in the gastric stimulator was higher, 26% versus 4%. And that's expected since it requires surgical intervention as compared to the GPOM. And then the conclusion was among patients with refractory gastroparesis, the clinical response is better and it lasts longer with the GPOM compared to gastric pacemaker or gastric stimulator. That's all what I have today. I'm happy to take any questions. I
Yes,
hope it wasn't too complex.
thank you very much, Dr. Zach. We do have quite a few questions, so I'll just go through them and ask them. This one goes back to sort of towards the beginning of the presentation. Someone was asking, what do you mean about a viral infection being self-limiting? Could you explain that a little more?
Yeah, we don't know the mechanism very well, but like usually viral infection is self-limited, right? So it resolves on its own. So patients with like different kind of viral, like for example, COVID-19, it's a self-limited disease, right? It resolves on its own. So it can slow down the stomach during the acute infection phase, but it can also last a little longer. Usually, it resolves on its own. So the gastroparesis will resolve on its own. So it will improve spontaneously without a need for intervention. Those are the patients that we can consider treating with medications, assuming that hopefully they're going to get better soon.
Thank you. And for some people, the presentation might have just frozen very briefly around you mentioning Ozempic. So just if you could revisit that and what the causes for surgery would be.
The causes for surgery. I don't understand the question. I think I know what you're talking about. No, I mean, so surgery is one of the reasons why people can get gastroparesis, because it can sometimes, whatever surgery, nothing specific, but any surgery that can lead to an injury to the vagus nerve, that's when people can get gastroparesis. Ozempic is something different. So Ozempic is a medication that is currently used for diabetes. It's an awesome medication for that. It can also be used for weight loss, and it also really work really well. But unfortunately, it slows down the stomach motility, so the stomach would not contract as well. And that's actually the mechanism of how it's being used for weight loss, because patients don't feel like eating. It decreased appetite. They feel nauseous after they eat. It's an important cause of gastroparesis, especially in patients with diabetes.
Thank you. And next question, if you could talk more about how cannabis causes the condition. I know you'd mentioned cannabis a little bit.
Yeah, it's again, it can decreases the motility of the stomach. Same mechanism, like it just decreases the contractions of the gastric muscles. Uh, uh, that's how it slows down the stomach and delays the gastric emptying, basically. We use it. We see it very frequently. Patients coming with nausea and vomiting, and as I mentioned, we check for gastroparesis and it comes back positive. But when I check with the patient has been on cannabis, on marijuana, they're smoking every day, in that case, I ask them to stop it for just like 4 to 6 weeks to get rid of the marijuana from the body, and then we redo the gastric emptying study, and we see improvement. So that tells me that the patient probably does not have a gastroparesis. It's or they do have gastroparesis, but related to the cannabis, and the cannabis should be stopped in that case. Ironically, though, very frequently patients with nausea and vomiting, their symptoms improve with marijuana use, and so it does improve symptoms short term, but it can affect the stomach long term. So I always recommend stopping marijuana or avoiding marijuana completely.
Thank you. And someone asked, what is ototoxicity? You had mentioned that in your presentation.
Oh, ear toxicity, like toxicity to the ear, like the ear.
Oh,
Yeah.
okay.
We're
Um,
talking about the inner ear, not outside.
okay.
Yeah.
Thank you. And is it okay to take Januvia? They weren't clear on what you were saying about Januvia.
Yeah, so actually, so Januvia is one of the medications that can be used for diabetes, but it does not affect the gastric motility. So it does not delay the gastric emptying. So I used it as an example for patients who are diabetic, who need diabetic medication, but they on the same time they have gastroparesis from diabetes, and they can't use the other medications like the Ozempic. They can use Januvia because it does not delay the gastric empty.
Thank you. One person had noticed they were having severe bloating after eating over the past few months, type 2 diabetes, and on metformin and Trulicity. They do have an appointment to see a gastro, but just if you had any comments on that.
Most likely, if this patient comes to my clinic, most likely if they're already on Trulicity, Trulicity itself can delay gastric emptying. If they stop Trulicity and the symptoms improve, great. No further treatment is needed or no further workup is needed. If they stop Trulicity and they're still having symptoms after eating, then in that case, we need to evaluate for gastroparesis, because gastroparesis can happen from diabetes itself. Usually, diabetes will lead to gastroparesis when patients usually have other complications from diabetes. So they have some eye problems, they have like a neuropathy, they have kidney disease from diabetes. So diabetes should be there for long term, for years before it can cause gastroparesis.
Thank you. We have a few questions about the clips and how they stay there a week or longer. Where do they go? Do they dissolve? And then just about cutting the pylorus and how does that help and how does that work?
Yeah, so the clips, even though they look big on that video I showed, they usually like this big in reality. So they're very tiny. So they're like less than like they're like less than 5 millimeter in length. So usually patient once it detached from the stomach wall, it will be passed in the stool. Patient will poop it out without knowing, without feeling anything.
Thank you. And then how is a pyloric issue diagnosed? What percentage of patients' issues stem from a pyloric issue?
Repeat the question again.
What percentage of patients' issues stem from pyloric issues, and how is a pyloric issue diagnosed?
So again, here in those patients, the pylorus is normal. So they don't have any pylorus problems. So the pylorus is functioning well. What they have is the stomach is not pushing the food through the normal pylorus appropriately, because the muscles are weak. Okay. So what we do, so the pylorus has no issues, absolutely no issues. But what we do with the procedure is the goal is to make the opening a little bigger. So hopefully the weak contractions in the stomach will be more effective in pushing the food forward. So there is no issue with the pylorus here.
Thank you. And we're doing great on time. We have just one more question. Um, Someone is asking, why would someone get surgery versus the GPOM?
So GPOM, as I mentioned, is a new. It's not available everywhere. So, for example, in our region, it's only available here at Bay State. It's a new, so it was the first case on a human patient was in 2013. So it has been there for like a little bit more than 10 years. But again, not everywhere. We just started doing it here at Bay State for a year ago. And the pyloroplasty has been, or the surgery has been the kind of the standard of care before this procedure came out.
Thank you. Well, that is all the questions. So thank you very much for joining, for giving us this wonderful presentation. Thank you to everyone for attending. Um, and if there are no other further comments, then hope everyone has a great night. Thank you.
Thank you so much.